A very warm welcome to everybody. Thank you very much for joining us for this CPD, where we're going to talk about imaging the acute abdomen using ultrasound. A few introductions before we begin. My name is Ian Jones, and I'm a radiologist. I graduated from the Royal Veterinary College in 2004, and I got my certificate in imaging in 2009. I recently was awarded my European Diploma in Imaging in 2018. And you can find me at London Veterinary Specialists, which is a multidisciplinary referral hospital set in the heart of London, in Belsize Lane. And if you have any questions at all about this evening's CPD, or any questions or queries regarding anything imaging related, please feel free to drop me a line or get in touch using this email address. So all of you in first opinion practice will be familiar with the AFAST examination, which stands for Abdominal Focused Assessment with Sonography for Trauma. So this is an examination predominantly to look for fluid, and if there is fluid present, to try and make a decision as to whether or not you need to do anything about the fluid. So the AFAST examination is a little bit more complicated than just a fluid detection device. If we look back at the literature and we look back to the Journal of Emergency and Critical Care in 2011, we can see that in order to perform an AFAST examination comprehensively, we need to split the abdomen into 4 regions. Region 1 is called the diaphragmatico-hepatic region, and that's dorsally and cranially. Region 2 is the splenorenal region, and that's dorsally. We've got the cystocolic region, which is caudal, and that's region 3. And then region 4 is the hepatorenal region, which is the most dependent part of the abdomen. Now, it's possible to grade the amount of fluid that's present based on the number of segments where fluid is detected. So, for example, if you were to detect fluid in regions 3 and 4, you could grade the abdomen as a 2 in terms of the subjective amount of fluid that's present in that abdomen. However you decide to do it, and however you decide to grade these examinations, the question on everybody's lips is essentially, do I cut this patient if I find fluid? And really, my advice to you guys would be that if you see some fluid, then I would try and tap it. And after analyzing the fluid, if it turns out to be septic, then that patient needs to be cut. So what we need to try and do this evening is to take things a little bit further. So we're comfortable with the AFAST examination. We're confident that we can detect fluid if there's fluid there. But if we get to a point where we decide that we need to do an exploratory laparotomy, it'd be nice to have a little bit more information about what we're likely to find. So we can go beyond AFAST and start looking at a few of the other abdominal structures. And in this presentation, we'll take a look at the peritoneal and retroperitoneal space, the stomach, the small intestines, the pancreas, the liver, and the prostate. And the sort of things that we're going to be looking out for include a pneumoperitoneum, a peritoneal effusion, or a peritonitis when we're examining the peritoneal and retroperitoneal space. We're going to talk a little bit about how gastric and small intestinal ulceration might appear on ultrasound, and also how to detect gastric and small intestinal foreign bodies. We'll talk briefly about intussusceptions and about how they look on ultrasound. And we'll also just mention briefly the sorts of abnormalities you might find in the pancreas, the liver, and the prostate that might be responsible for an acute abdomen, more specifically pancreatitis, mucocele, and also abscesses. So getting back to the peritoneum and the retroperitoneum, if there is gas in the peritoneal cavity, either it's internal gas that's got out or it's external gas that's got in. If it's internal gas that's got out, then most commonly it's because of a rupture in the gastrointestinal system, be that a gastric ulcer or a duodenal ulcer, or a perforation secondary to a foreign body, more often than not, it'll be a little hole somewhere in the gastrointestinal tract that's caused that pneumoperitoneum. If it's not internal air that's got out, it's external air that's got in, that's usually secondary to some sort of penetrating injury. So it could be a dog bite or a cat bite, or any other sort of penetrating injury. So dogs sometimes manage to skew themselves on stakes and poles. Usually if it's external air that's got in, it's a little bit more obvious based on the signalment and the history. There are a few other things that can cause pneumoperitoneum. So a bladder rupture, for example. You wouldn't necessarily think of a ruptured bladder in a patient that has gas in its abdomen, but that can cause it. You can have caudal migration of air from the mediastinum into the retroperitoneal space, so that's worth bearing in mind. And also, the final one on this slide, iatrogenic causes. Now, this is extremely important to bear in mind. So if either you or one of your colleagues has done any sort of invasive procedure, be it only a cystocentesis or an FNA or an abdominocentesis, in a patient, and you subsequently detect gas in the abdomen, it's very difficult to know whether the gas that you're picking up in the abdomen is secondary to that procedure, the abdominocentesis, the cystocentesis, the FNAs, or due to genuine abdominal pathology. So I'd always recommend making sure that there is no evidence of a pneumoperitoneum prior to sticking any needles in the abdomen. Because if you decide to do abdominocentesis first, and subsequently during your ultrasound examination you detect gas in the abdomen, you've got no way of knowing if that gas is real and secondary to, say, a perforated duodenal ulcer, or if you've introduced that small amount of gas while you were doing abdominocentesis. Also, if that patient has had abdominal surgery recently, that can be a cause of iatrogenic pneumoperitoneum. So a patient, for example, that's had an XLAP and had an enterotomy in the last week or so, there might still be a little bit of gas in that abdomen. And what you don't want to do is you don't want to diagnose that patient with a leak or a ruptured GI tract when simply it's as a result of the surgery it's had done previously. So be very, very careful about iatrogenic causes of pneumoperitoneum. Pneumoperitoneum appears as hyperechoic lines normally with distal shadowing, and you'd also see a reverberation artifact with gas. So let's take a little look at a still image of pneumoperitoneum. So here, what we can see is the abdominal wall. And then helpfully, we have two little arrows here and here pointing out this little gas pocket that's formed in the non-dependent part of that peritoneal cavity. And we've got this linear hyperechoic line, and then we've got this reverberation artifact in the far field relative to that hyperechoic line. And that is absolutely typical of gas within the peritoneal cavity of a pneumoperitoneum. So if you see this in a patient that has not had any invasive procedures performed at all, nobody's done abdominocentesis, nobody has done a cysto, nobody's done any FNAs, this patient hasn't had any abdominal surgery recently, that's a reason to be very concerned indeed. This patient has free gas in his abdomen, and we need to be very concerned as to what might have caused that. As well as a pneumoperitoneum, there's also peritoneal effusion. So peritoneal effusion, pneumoperitoneum, and peritonitis often go together. So if we are to detect a peritoneal effusion, so fluid in the abdominal cavity, the literature suggests that you need to have at least 2 mils per kilogram of fluid. Now, that's based on a paper that was published in Veterinary Radiology and Ultrasound way back in 1989. And I think we're probably a little bit more sensitive at picking up fluid these days. But as a general rule, I think 2 mils per kilogram is a reasonable amount of fluid to expect to find before it becomes detectable. Coming back to the AFAST examination, fluid will always form in the most dependent part of the abdomen. And that's the place that you guys should be looking predominantly. So this is another illustration of how you perform an AFAST examination. So really the region that you guys need to be concentrating on is region 4. So region 4 is the most dependent part of the abdomen. It's the part where fluid is going to pool with the patient in lateral recumbency, because the fluid is always going to follow gravity. So I can't think of too many instances where you're going to see fluid in regions 1 and 2, but not in regions 3 and 4. So fluid, it's always going to be in the dependent part of the abdomen. It's always going to follow gravity. It's always going to go down towards the table. So in order to see fluid in regions 1 and 2 and not in regions 3 and 4, I mean, really, you'd have to be picking up pockets of fluid. Fluid within cavities, within the peritoneal cavity. So abscesses, for example, might appear in regions 1 and 2 as focal accumulations of fluid, but that's pretty rare. 99 times out of 100, you're going to see fluid in regions 4 and regions 3. So these are the regions that you guys need to concentrate on. We sometimes need to be objective, or as objective as we can possibly be, about whether the fluid that we've previously detected in an abdomen has increased in volume or not. And the way to do this, again, this is very subjective. With the patient in right lateral recumbency, just touch the probe against the most dependent part of the abdomen, just like it's shown here in region 4, at the level of the umbilicus. And just very roughly measure the amounts of fluid that's present. So in this instance, there's not very much fluid at all, so there's about 0.5 centimeter of fluid. And if you are doing a series of ultrasound examinations on that patient to try and decide if the fluid is increasing in volume, you essentially just repeat the process. So the patient goes back into right lateral recumbency, and you pop the probe again on the dependent part of the abdomen at the level of the umbilicus, and then repeat the measurement. And if you find that the depth of the fluid is increasing, so if this depth here is increasing, so if we've gone from, say, 4 millimeters up to 10 millimeters, up to 2 centimeters, then you can be reasonably confident that that peritoneal effusion is increasing in volume, and you might need to do something about it. And I've been asked to do that most commonly in patients that have a hemoabdomen, and the clinician is concerned that there's ongoing hemorrhage. So that's just a little tip about how you can sort of semi-objectively define an increase in volume in the peritoneal effusion in, say, patients with a hemoabdomen that are suspected of having a continuous bleed. So having discovered that there's peritoneal effusion, the literature would have us believe that we can predict the type of effusion. So the more anechoic an effusion is, the more likely it is to be transudate or modified transudate. And the more echogenic an effusion is, particularly if it's full of hyperechoic fibrinous strands, the more likely it is to be a purulent exudate. And then modified transudates, chyle and hemorrhage, are kind of somewhere in between. I've certainly heard people say that if you have an effusion that has lots of small motile echogenic particles, then it's more likely to be hemorrhage. So we've got an image here, and what we can see is some peritoneal effusion, which is here, and then we've got all of these echogenic particles in this effusion. So I would really classify this peritoneal effusion as being really quite highly echogenic, and this effusion and these particles are also very highly motile. So when this patient was breathing, we could see these particles swishing around in the abdomen. Now, just looking at the appearance of this effusion and those echogenic particles using ultrasound, we might say, I think this is more likely to be hemorrhage, or maybe more likely to be something proteinaceous like a modified transudate or an exudate. And this just turned out to be a transudate. So my advice to you would be, don't make predictions about what the fluid is likely to be. If you see fluid, then tap it and decide what that fluid is by analyzing them. So along with peritoneal effusion, we often get peritonitis, and the peritonitis we diagnose based on changes that we see to the mesenteric fat. So the mesenteric fat, when it gets inflamed, tends to get thicker and brighter. So when we're looking for peritonitis, we're looking for thick, hyperechoic mesenteric fat. So this is an ultrasound image taken from a 15-year-old male neutered cat that actually presented for urethral obstruction. And in this image, we can see quite a large amount of peritoneal effusion. This structure just here is the spleen, and there is a little splenic nodule here. It's reasonably clearly marginated, and it's hypoechoic relative to the adjacent splenic parenchyma. However, I'd like you guys to just try and ignore the spleen here, concentrate on the fact that there's a moderate volume peritoneal effusion, but more on the appearance of the mesenteric fat in the far field relative to the spleen. So this fat is thick and it's bright. So we've got evidence of a peritonitis here, which is associated with this moderate volume peritoneal effusion. So for peritonitis, we're looking for thick, hyperechoic mesenteric fat, and more often than not, if you guys have picked up peritoneal effusion, even if it's a small volume peritoneal effusion, then there will be an associated peritonitis. So moving on to the gastrointestinal tract and starting at the start, which is the stomach, let's talk a little bit about gastric ulceration. So gastric ulcers usually appear as a defect in the wall of the stomach. You sometimes see gas permeating the gastric wall, and if you see that feature, then that really nails it on as a gastric ulcer. As well as there being gas within the wall also tends to look thick and hypoechoic, so there'll be loss of wall layering associated with those other changes. So here's an image taken from a 12-year-old male neutered dachshund that presented to us vomiting, and hopefully you guys can see some changes to this stomach wall. So all of this is the stomach, and this is the gastric wall here. So this gastric wall is way thicker than it should be, and also we've got loss of wall layering. So normally I'd expect to see all the different layers of this gastric wall, so mucosa, submucosa, muscularis, and serosa, and instead of that, we've just got this uniform hypoechoic tissue. And if we look at these small arrows here, what these small arrows are pointing out is a hyperechoic curvilinear structure within the gastric wall with some associated reverberation artifact. And that's compatible with gas permeating this gastric wall. So here we've got a very thick gastric wall with loss of wall layering that's uniformly hypoechoic, and we've got evidence of gas permeating this gastric wall. So all of those features are compatible with a gastric ulcer. The other thing that you might find in the stomach of a patient presenting with an acute abdomen is a gastric foreign body. Now, these patients usually have a big dilated stomach because they're essentially obstructed. Their stomach usually isn't able to empty and push the contents out of the pylorus into the duodenum. So a big stomach that's got a whole bunch of fluid and gas in it. And in amongst all of that fluid, gas, and usually particulate ingesta, you will come across a bright interface that is strongly shadowing. And it's that bright interface that's strongly shadowing that is our gastric foreign body. So this ultrasound image was taken from another dachshund, a 13-year-old male neutered dachshund that presented to us vomiting. And hopefully you guys can see that we have a hyperechoic curvilinear interface here and beautiful, strong, uniform shadowing associated with this structure. And it's this shadowing that really nails it on as a gastric foreign body. So this patient had endoscopy, and we managed to remove a ball, as well as a bunch of other stuff from this dog's stomach, including a mixture of grass and chewing gum, and a whole bunch of other horror that had all stuck together in the gastric lumen and was causing a gastric outflow obstruction. So as well as having foreign bodies in the stomach, it's also possible to get small intestinal foreign bodies that cause a mechanical ileus and can cause all sorts of problems. If you have a mechanical ileus and you have an obstructed patient, one of the things that you really need to look out for on ultrasound is the presence of two distinct populations of bowel. One will be dilated and the other will be empty. The dilated segments of bowel will be ORAD to the obstruction, and the empty sections of bowel will be ABORAD to the obstruction. So you don't necessarily need to see the obstruction, to see the foreign body, to see the thing that is causing the mechanical ileus. If you see two distinct populations of small bowel, one dilated, one empty, that's a good reason to be very suspicious that there's something sinister going on, and that patient might have a mechanical ileus, an obstruction, a foreign body that needs some attention. As well as two populations of small bowel, depending on how long the obstruction has gone on for, will depend on the other changes that you're likely to see associated with that. So you can often see a peritoneal effusion and a peritonitis in a patient with a mechanical ileus secondary to a foreign body. Just like the gastric foreign bodies, small intestinal foreign bodies appear as a structure with a very bright, high pyrochoic interface and very strong shadowing associated with them. So gastric foreign bodies, bright interface, strong shadowing. Small intestinal foreign bodies, bright interface, strong shadowing. Just a word of caution at this point. It is extremely important that we are able to tell the difference between the strong, uniform shadowing that we are likely to see in association with either a gastric or a small intestinal foreign body and reverberation artifact secondary to gas in the colon. We do not want to get those two mixed up and be recommending exploratory laparotomies in patients that just have a colon full of gas. So let's take a look at some examples of each. So the image on the left here is of a small intestinal foreign body. So hopefully you guys can appreciate that this is definitely small bowel. So if we look at this section of bowel that's actually just ORAD to this foreign body, we can see that it's thick and we've got beautiful wall layers. So mucosa, submucosa, muscularis, and serosa. So there's no doubt at all that this is small intestine. We've got this hyperechoic, curvilinear structure with beautiful, strong, uniform shadowing. So this is definitely small bowel. This is definitely shadowing. This patient definitely has a small intestinal foreign body. If we look at the image on the right, we can see that this isn't small bowel at all. This is actually colon. So the colonic wall, much, much thinner than the small intestinal wall. And even though it has the same layers as the small intestine, these layers are much harder to see. So this is colon, no question. If you compare how the wall layering looks here to how the wall layering looks here, they're very different. And even though there is some shadowing here, it's very dirty shadowing. And it's dirty because of all the reverberation artifact that we're seeing here. So this is gas in the colon. This is not a small intestinal foreign body. This is colonic wall. This is reverberation artifact. This is gas in the colon. This is small bowel. This is strong, uniform shadowing. This is a small intestinal foreign body. So it's really important you guys are able to tell the difference between the two, because like I said, you don't want to be recommending surgery in patients simply because they have a colon full of gas. And a lot of patients that have gastroenteritis, for example, are going to present as vomiting, and they're often full of gas. So it's really important that you can tell the difference between shadowing and reverberation artifact. So just for a bit of fun, we're going to look at a few foreign bodies that we've removed from some patients at LVS over the last 6 months or so. So this first one was taken out of a 1-year-old male-neutered domestic short-haired cat that presented as vomiting. So this structure is not particularly big. It's about 3 centimeters long. and about 1.5 centimeters thick. One end is curved and the other end is straight. And the periphery of this structure has a slightly different density to the center. So the periphery is a little bit more dense. And in fact, in the center, we've got a whole bunch of reverberation artifact compatible with gas. So what could this be? We've got a 3 centimeter long, 1.5 centimeter thick structure that's curved at one end, straight at the other, and is full of gas in the center. If any of you guys guessed that this could be a foam earplug, then you would be absolutely right. And that's exactly what this turned out to be. So this is one of those little foamy yellow earplugs that are really common. And for whatever reason, this cat had decided that the best thing to do with this earplug was to eat it and get obstructed and have to have surgery to have it removed. So this is foreign body number 2. So this is an image taken from an ultrasound examination of a 1-year-old male entire Cocker Spaniel that presented vomiting. This is an image of the stomach. So this is the gastric wall. We've got this very straight, linear, high pyrochoic structure that is within the gastric lumen. We've got this beautiful, strong, uniform shadowing associated with this structure. And this structure is so big, it's deforming the stomach wall. So any ideas what this structure might be? It's big, it's straight, it's deforming the stomach wall. So this structure turned out to be a kebab stick, and it looked a little bit like this at surgery. So this is a non-invasive laparoscopic procedure to remove this kebab stick from the stomach. So you can see it just here as it's coming out. And if anyone is interested in seeing a little bit more of this procedure, there is a video on our website that you can have a look at, and it's at this address. So our last guess, the foreign body for now, this one was found in a 5-year-old male-neutered puggle. This structure here is the foreign body. It's 2 centimeters long and it's 1 centimeter thick. And hopefully you guys can appreciate that the ORAD bowel is quite dilated here. Again, it has a curvilinear surface, and it's very rough, this surface, so it's all bobbly, and we've got this strong acoustic shadowing associated with it. So any idea what this might be? So all of you guys at home that guessed that this could be a peach stone would be absolutely right. So that's what was pulled out of this little puggle. So if you guys think about how a peach stone looks and how rough the surface of a peach stone is and all the little indentations you get on the surface of a peach stone, that's what we can see here on this surface. And fruit stones, like a peach stone, pretty common reason for patients to get obstructed. So this one is worth sticking in the memory bank. It's worth thinking about linear foreign bodies in isolation because they tend to appear very differently to foreign bodies like peach stones, for example. Again, you're going to see a hyperechoic linear interface and strong shadowing, but you're also going to see plication of the small bowel around the linear foreign body. And these linear foreign bodies tend to crop up in pretty predictable places. So in the dog, linear foreign bodies quite often will get anchored at the pylorus and then extend into the duodenum. In cats, if you have a cat that's vomiting and you see anything at all that you think might be compatible with a linear foreign body, then it's worth just checking underneath the tongue. So I've seen quite a few cats that have linear foreign bodies that are anchored underneath the tongue. So in dogs, these linear foreign bodies are more often going to anchor at the level of the pylorus. In cats, if you think a cat might have a linear foreign body, then make sure that you check under the tongue. They're very easy to miss. So here are some images taken from an 8-year-old female neutered beagle that presented as vomiting. The image on the left here is of the stomach. So this is the stomach wall just here, and that's a whole bunch of fluid echogenic particulate ingesta. And then we've got this hyperechoic interface. It's a pretty irregular shape, and then again some strong acoustic shadowing that's associated with this structure. And if we follow the structure into the duodenum, what we'll see is what we have illustrated on the right here. So this is the duodenal lumen, and hopefully you guys can appreciate that there's a linear hyperechoic structure within this lumen that shouldn't be there, and we've got beautiful plication of the duodenal wall. So if you follow the duodenal wall along the edges of this linear hyperechoic structure, then you can see it's wonderfully plicated. So it's almost like an accordion scrunching up around that linear foreign body. So we've got shadowing material accumulating within the stomach at the level of the pylorus. We've got a linear hyperechoic structure extending from the pylorus into the duodenum, and we've got this wonderful plication of the wall of the duodenum around this structure. So this patient has a linear foreign body, no question. And if you were curious as to what this might look like at surgery, it looks a little bit like this. So here we have the duodenum that we have just examined using ultrasound, and that concertinaed small bowel that's scrunching up around the linear foreign body will look a little bit like this when you guys get in there and do the surgery to remove it. So that's how plication looks in 3D. Now, just a word of caution for you guys. It's extremely important to know the difference between plication of the small bowel and corrugation of the small bowel. So we've got two images here. The image on the left is taken from the case that we've just discussed, and it's plication of the small bowel. The image on the right is taken from a patient that presented with vomiting and diarrhea, but turned out to just have gastroenteritis, and this is corrugation of the small bowel. So let's just take another look at the plicated bowel. Here we've got a linear foreign body within the lumen. So already we're concerned that this is something that might require removal and exploratory laparotomy. And if we look at the wall, it's concertinaed, it's accordioned up around that linear foreign body. It's all bunched up, and we should be able to follow these little pockets of the duodenal wall around this linear foreign body. And this is plication, and this is something that is pretty much pathognomonic for linear foreign body, and it's something that we need to be really concerned about, because if we see this, then this patient needs an XLAP. The image on the right is small bowel that is corrugated. So the margins of the small bowel are a little bit undulating, and it's certainly abnormal, but it isn't plicated. It's just corrugated. The shape of it is a little bit like corrugated iron, so a little bit like the corrugated iron sheets that you might use to roof a shed or something like that. It's corrugated, the margins are smooth, they're undulating, there's nothing in the lumen here, and it's not bunched up around anything in the lumen. So this is just corrugation. Very important that you guys can tell the difference between the two, because this patient that has a plicated small bowel and a linear foreign body needs surgery to remove it. This patient that just has corrugated small bowel could potentially just be treated medically. So there's lots of different causes for corrugation. You see it quite often if the bowel is inflamed in patients that have gastroenteritis. There are a few other things that can cause it, like ischemia, for example, but usually it's inflammation. You'll see it in patients that have a really nasty gastroenteritis. The bowel is really inflamed and really angry, and then it gets a little bit corrugated. These patients you can treat medically. These ones need surgery to remove the linear foreign body. One of the things that you can see associated with the linear foreign body is an intussusception. So an intussusception is basically the bowel enveloping itself over the linear foreign body, and it has a very characteristic appearance. It's multi-layered and almost looks a little bit like a target, and that's because of the multiple layers of intestinal wall that make up the intussusception that are usually interspersed by mesenteric fat. So we take a look at this diagram that's taken from Pennick's ultrasonography textbook. What we can see is the typical appearance of an intussusception, B, and this is sort of the classic appearance, the classic target appearance that we're looking for when we're diagnosing an intussusception. So we've got an outer intestinal wall, which is the intussuscipiens. We've got an inner intestine, which is the intussusceptum, and then we've got this mesenteric fat between the two. And this is how it looks in short axis, and this is how it looks in long axis. And normally you're going to have an obstruction associated with the intussusception. So the small intestine ORAD to the intussusception is going to be very dilated, and the bowel alborad to it, so away from the mouth, is going to be pretty empty. And again, we can see that illustrated in the diagram here, very dilated bowel ORAD and empty bowel alborad. So here's another example of an intussusception in A. We can see a jejunal intussusception secondary to a linear foreign body. So here, as well as having the different layers of bowel, so the outer layer, the intussuscipiens, the inner layer, the intussusceptum, we've also got this hyperechoic structure with associated shadowing in the center. So that's a linear foreign body that has an intussusception associated with it. This is how it looked in short axis, and this is how it looked in long axis. In long axis, it's pretty difficult to make any sense of what's going on here, other than there's this shadowing structure in the lumen, and then a whole bunch of small intestine and small intestinal wall layering that really shouldn't be there, interspersed by layers of mesenteric fat. So small intestinal ulcers certainly can be a reason for a patient presenting with an acute abdomen, a septic peritonitis, particularly if they rupture. And just like with the gastric ulcers, what you'd expect to see is a thickened intestinal wall. You'll see some loss of wall layering. You might see some discrete mucosal defects. And again, as with the gastric ulceration, if you see gas permeating the intestinal wall, then that pretty much nails it on as a small intestinal ulcer. As well as the changes to the intestinal wall, you might also see a peritonitis associated with it. And if the ulcer has ruptured, then you're also going to see a pneumoperitoneum. And you guys know how to diagnose a pneumoperitoneum using ultrasound now. These are some examples of small intestinal ulceration, again taken from Dominic Pennick's ultrasonography textbook. In A, we can see that we have thickening of the wall of the small bowel, as well as permeation of the wall with gas. So these little arrowheads are pointing to gas that's extending into the wall of the small bowel. And in B, as well as seeing gas within the wall of the small bowel, we've also got associated peritoneal effusion here, illustrated by this little asterisk, and then we've got a peritonitis. So this mesenteric fat just next to this peritoneal effusion, and this ulcer is looking very thick and very inflamed. So an ulcer and an associated peritoneal effusion and an associated peritonitis, and certainly those changes quite often go together. Another word of caution for you guys is don't get a small intestinal ulcer mixed up with a Peyer's patch. So in the image on the left here, we're taking another look at the example of small intestinal ulceration that we've just analyzed. So we've got thickened wall, loss of wall layering, gas permeation into the intestinal wall. This is a small intestinal ulcer, and this is something that we need to be worried about. The image on the right here is a Peyer's patch. So a Peyer's patch is just an accumulation of lymphoid tissue within the intestinal wall, and often in patients that have a non-specific gastrointestinal disease, the lymphoid tissue can get engorged, and this is how they can appear. So you tend to see a focal area of increased echogenicity within the intestinal mucosa. So this is just a Peyer's patch. You see them in the duodenum, and it's nothing too much to worry about. So this is a non-specific finding, and it certainly doesn't require anything more than some medical treatment in the first instance. This is a small intestinal ulcer. This is something to be very concerned about. If there's a small intestinal ulcer here, it could have ruptured. Has it ruptured? Is there pneumoperitoneum? Is there peritonitis? Is there any peritoneal effusion? If there's an effusion, can we tap it? Is this dog septic? This is just a Peyer's patch. Nothing too much to worry about. So it's very important that you guys can tell the difference between the two, ulceration and Peyer's patches. When we're looking for the pancreas and at the pancreas in patients presenting with an acute abdomen, we're invariably looking for any evidence of a pancreatitis. And when we're evaluating the pancreas in the dog, we tend to concentrate on the right lobe of the pancreas. So to find the right lobe of the pancreas, my patients are usually placed in left lateral recumbency. You find the right kidney, slide the probe ventrally until you find the duodenum, and then rotate the probe 180 degrees to get a nice short axis view of the pancreas. In cats, we tend to spend more time looking at the left lobe. So patients are in right lateral recumbency, and you need to find a little triangle of space in between the stomach, the spleen, and the colon, and that's usually where you'll find the pancreas. It can be a pretty tricky organ to nail down, but once you get used to the landmarks, you'll be able to find it consistently. And these are some examples of how I'd expect the canine and the feline pancreas to look. So the canine pancreas, we can see the duodenum just here, and we can see the pancreas just adjacent to it, and we can see the pancreatic duct. This is a nice normal pancreas. Feline pancreas, we've got the spleen here, and the stomach is going to be just here, and the colon is going to be just here caudally. And again, we've got the pancreas in between these three organs, so that's our little triad, and we're looking at the space in between, and this is the little pancreatic duct here. So this is a feline pancreas, and this is a canine pancreas. If a patient has pancreatitis, then the pancreas is going to get big, so you're going to see an enlarged pancreas. Because it's increased in size, it's going to have rounded margins. It's going to look darker, so it's going to be hypoechoic, black, and the fat around it is going to get very, very inflamed. So you're going to get very thick, hyperechoic peripancreatic fat. Now, in terms of, well, how do I know if the pancreas is enlarged? If you look at the literature, I think the mean thickness of the right lobe of the dog is about 8 millimeters, and the mean thickness of the left lobe in a cat is about 6 millimeters. For me, as a general rule, if the pancreas is thicker than a centimeter, then it's too big. You need to take a closer look at it and look for any additional evidence of pancreatic disease. So this is an example of a cat with chronic pancreatitis. So here we can see that the pancreas is too big, it's too dark, and the fat around it is too bright. So this is a thickened hypoechoic pancreas with smooth rounded margins and thick hyperechoic peripancreatic fat, and that's compatible with a pancreatitis. Another just word of caution when looking at the left lobe of the pancreas in cats. The size of the pancreatic duct can increase in elderly cats. So the image on the left here is a long axis image of a normal left pancreatic lobe from an older cat. And hopefully you guys can appreciate just how giant this pancreatic duct is. Now, a big pancreatic duct in an old cat is simply an incidental age variant. It's not a symptom associated with any sort of pancreatic disease, and it's certainly not a reason to be diagnosing that cat with pancreatitis. A big pancreatic duct in an elderly cat is nothing at all to worry about. A pancreas that looks like this, which is the case that we've just been discussing, is something to worry about. So this pancreas is too big, it's too dark, it's too round, and the fat surrounding the pancreas is too bright and too thick. This is an old cat with a normal pancreas and a big pancreatic duct. This is a cat with pancreatitis. Now, as well as pancreatitis, very, very occasionally, you can see pancreatic abscesses. They're pretty rare. I've not seen too many of them. Effectively, an abscess represents a circumscribed collection of pus. You tend to see them more in dogs than in cats. Their sonographic appearance is pretty non-specific, so you really have to stick a needle in these to be confident about making a diagnosis of pancreatic abscess. So I've not seen too many of these. So these are again images taken from Dominique Pennick's ultrasound textbook. And what we can see in A is an image taken from a 6-year-old Cocker Spaniel. And there's an ovoid, discrete, hypoechoic structure that's associated with the pancreas. We've got the duodenum somewhere here, and we've got an associated peritonitis. So the peripancreatic fat is very thick and very hyperechoic. In B, we've got a similar lesion. This is taken from an exam of a 10-year-old Labrador cross. And again, there's a discrete mass associated with the pancreas. It's hypoechoic, and there's evidence of inflammation of the peripancreatic fat. So this is how a pancreatic abscess might look. So essentially a discrete hypoechoic pancreatic mass with associated inflammation of the peripancreatic fat. So it's very difficult to differentiate that from, say, a neoplastic lesion. So something like a pancreatic carcinoma might look very similar. So you really do need to stick needles in these to be confident that they're abscesses. This is an interesting case that we saw recently at LVS. So this is a 12-year-old female neutered domestic shorthair that presented to us as polyphagic. It was persistently hypoglycemic, and we popped the probe on this cat's abdomen and found that the pancreas was really severely enlarged. The echogenicity was grossly abnormal. It was very, very heterogeneous, and as well as having a huge pancreatic duct, there was a lot of very echogenic material accumulating in this pancreatic duct, which was very unusual. We took some FNAs of this pancreas, and they were compatible with a severe necrotizing pancreatitis. And this patient, unfortunately, went on to develop a septic peritonitis and was euthanized. However, the most interesting thing about the cytology was, as well as there being evidence of a severe necrotizing pancreatitis, there was also evidence of Tritrichomonas organisms within the pancreatic FNAs. So the working diagnosis for this patient was that it had an ascending Tritrichomonas infection of its pancreas via its pancreatic duct, which resulted in a severe necrotizing pancreatitis and a subsequent septic peritonitis. So moving from the pancreas to the liver, mucoceles are something that you guys will come across from time to time. The more often you put the probe on older dogs' abdomens. Mucoceles are essentially just an accumulation of mucus within the lumen of the gallbladder, and they have a very characteristic appearance. So it's often described as a kiwi-like pattern. So if you imagine cutting a kiwi fruit in half and then taking a look at the half, then you should see a beautiful stellate pattern. So you'll see black lines extending from the center of the kiwi towards the periphery. And that's really what we're talking about when we talk about this kiwi pattern in mucoceles. If you see a mucocele and you're seeing evidence of a discontinuous wall or a local peritonitis, then those are reasons to be a little bit concerned, because if the wall looks discontiguous and if the fat around the gallbladder is thick and hyperechoic, so if there's any evidence of a local peritonitis, it could mean that that mucocele has ruptured. The patient now has effectively a bile peritonitis. So this is what you'd expect to see in an older dog with a mucocele. So this is the gallbladder here. The gallbladder wall is very thick and hyperechoic, and we've got this stellate kiwi-like pattern in the center of the gallbladder. So this is an incomplete stellate pattern. It's pretty typical for a mucocele. Here we can see that the fat adjacent to the gallbladder is quite thick and hyperechoic. So there is some evidence here of a local peritonitis. So we need to be concerned that this mucocele may be leaking and that this patient needs surgery in the very recent future. So hepatic abscesses, again, not very common. Something that I've seen a couple of hepatic abscesses that they have a pretty non-specific appearance on ultrasound. They tend to appear round or oval. They're usually hypoechoic. Sometimes they're cavitary, so you can see these accumulations of fluid within the abscess. If you see gas present within the structure, then that really nails it on as an abscess, and you can see a local peritonitis associated with them. But just like the pancreatic abscesses, to really nail it on as an hepatic abscess, you need to do an FNA to confirm it. So here's an example of an hepatic abscess that we saw in a 4-year-old male entire Pomeranian. This patient presented as lethargic, anorexic, and hypoglycemic. It was also pyrexic and neutropenic. So what we have here is a poorly marginated, heterogeneous lesion within the liver. It's distorting the hepatic shape, so there's bulging of the hepatic capsule. It's pretty non-specific in terms of what it might be, but we FNA'd this lesion, and the cytology was compatible with an hepatic abscess. So they are out there, so watch out for them. Prostatic abscesses are probably the abscesses you're most likely to come across, and they have a very similar appearance. They are usually hypoechoic. More often than not, we'll see cavities or septation of the lesion. The walls tend to be thick, and they can sometimes be mineralized. You might see anechoic or potentially maybe even some echogenic fluid within these structures. Again, if you see gas inside them, that really nails it on as an abscess, and associated with them, you can see some local peritonitis. Again, it's worthwhile FNAing or sampling these structures in order to get your diagnosis. So here's an example of a prostatic abscess that we saw recently in a 10-year-old male neutered Staffordshire Bull Terrier. So this dog presented with chronic hematuria, stranguria, was also lethargic and anorexic. And what we can see here is a prostatic lobe. And within this prostatic lobe, we've got this large, clearly marginated structure. Some of it is hypoechoic, and some of it is quite echogenic. And if we look at a short axis view of the same structure, we can see that in the non-dependent part of the structure, we've got this more hypoechoic fluid, and in the dependent part of the structure, we've got this very echogenic fluid. So we've got all of the most dense cellular debris that's within this abscess settling in the most dependent part, and then all of the least dense fluid accumulating in the non-dependent part. So we completely drained this abscess, and I think the patient, if I remember rightly, was treated medically and did very well. So just to finish off, we're going to look at a couple of cases just to see if you guys have been listening to the presentation this evening. So case number 1 is a 3-year-old female neutered domestic short-haired cat. It's presented to you because it's been anorexic for the last 2 days, and it's also vomited multiple times. So I'm just going to run through 3 ultrasound images taken from the examination of this cat. So this is our first image, and what we can see here is some small bowel. So we can see this beautiful, thick, small intestinal wall and all of the layers, and this is the small intestinal lumen here, and we've got this hyperechoic curvilinear structure with very strong associated shadowing. If we move down the abdomen, then what we can see is we've got 2 distinct populations of small bowel. We've got this small bowel here, which is actually ORAD to the structure we were just assessing, and this small bowel here, which is aborad. So we've got very dilated small bowel ORAD to that echogenic shadowing structure, and we've got empty small bowel aborad to it. And not only that, we've got particulate echogenic ingesta settling in the dependent part of this dilated ORAD bowel. So let's just run through these images again. Small bowel, curvilinear hyperechoic structure, strong associated shadowing, dilated intestine ORAD, empty intestine aborad. So the question that we are always asking ourselves in these sorts of patients is, should I cut it? Yes or no? So this is the moment to decide whether or not you would be getting theatre ready. And if you decided to get theatre ready because we are going to need to cut this cat, then you'd be absolutely right, because this cat had a hairball or a trichobezoar that was causing a mechanical ileus. So the trichobezoar presented like a typical small intestinal foreign body, so a bright interface, strong associated shadowing, very dilated bowel ORAD, empty bowel aborad, so two populations of small bowel. And this cat absolutely was obstructed and absolutely needed an exploratory laparotomy and this trichobezoar removing. So case number 2 is a 10-year-old female neutered border collie. It's presented to you because it's vomited multiple times. So again, let's just take a little look at some of the ultrasound images that we acquired for this patient. So this is an image taken from the mid-abdomen. It's showing a couple of loops of small bowel. So this one in the far field is a little bit bigger than this one in the near field, but there's not really much in it. It's difficult to say that there's two distinct populations here. There's maybe just a single population. However, on closer examination, we can see that this is small bowel. That's probably also small bowel here. And again, we've got this big shadowing structure within the lumen of the small bowel. So that's certainly something to take note of and to be concerned about. And if we look just ORAD to the structure, we can see that the small bowel, that's a little bit bigger than it is elsewhere, but it's not huge. And then aborad to the structure, the small bowel is pretty empty. So just running through those images again, small bowel, large, curvilinear, bright structure, lots of shadowing. The intestine ORAD is a little bit bigger than the aborad intestine, but there's really not much in it. So same question, should I cut this dog or not? So for those of you who decided to wait it out, in this case, you would have been right to do so. So we repeated the ultrasound scan of this dog 24 hours later, and that foreign body wasn't visible. And this dog made a complete recovery just with symptomatic medical treatment. So this patient didn't need to have an XLAP. So this dog definitely had a foreign body, but it didn't have any evidence of a mechanical ileus. So we weren't seeing two distinct populations of small bowel, and the ORAD intestine wasn't hugely dilated relative to the aborad intestine. So this dog definitely had a small intestinal foreign body. It had no evidence of mechanical ileus, and therefore it was reasonable to adopt a wait-and-see policy, which turned out to be the right thing to do in this case because it made a complete recovery just with some symptomatic medical therapy. So our last case is an 11-year-old male neutered Staffordshire Bull Terrier, and again, it's just vomited multiple times. So we'll take a little run through some of the ultrasound images we acquired for this patient. So this is our first one. So already we can see that we've got lots of changes here that we need to be concerned about. So we've got two distinct populations of small bowel. This one in the near field is hugely dilated, and the ones in the far field definitely contain ingesta, but look a lot smaller than this loop in the near field. We've got some evidence of a peritonitis here as well. So this mesenteric fat is thick and hyperechoic, and there's some peritoneal effusion here too. Then on closer inspection, we find this structure. So we have a discrete circumferential mass lesion, which is originating from the small bowel. There's associated loss of wall layering. So this is certainly very, very abnormal indeed. And if we look aborad to the structure, we can see that there's a lot of hyperechoic shadowing material that's accumulated in the lumen of the small bowel, and that this bowel is really quite dilated. And then aborad to the structure, the intestine looks pretty empty. So same question, would I cut this dog or not? And for those of you who decided to cut this patient, you were absolutely right. So this patient had a small intestinal carcinoma, which was causing a chronic partial obstruction. So this patient had an end-to-end anastomosis performed and did extremely well. So this is the evidence of mechanical ileus, essentially. So two distinct populations of small bowel, one ORAD, very dilated, This is carcinoma. So here we've got a loss of wall layering. So we've got a mass lesion with loss of wall layering. So whenever you see that, you need to be concerned about something neoplastic. In this case, it's a carcinoma. In cats, intestinal lymphoma will often appear just like this. In terms of the appearance of the bowel ORAD and ABORAD, so this material here is effectively an ultrasound gravel sign. So if you guys think think back to evaluating abdominal radiographs, if you see a gravel sign, which is an accumulation of mineralized material within the abdomen, within the small bowel, then that's compatible with a chronic partial obstruction. And here we've got an accumulation of shadowing material, just ORAD, to this partial obstruction that's being caused by this intestinal carcinoma. So this is essentially what a gravel sign looks like on ultrasound. And it was absolutely the right thing to do to cut this patient, who I think went on to do pretty well. So that's it for now. As I say, if any of you guys have any questions at all about this session, or if you have any questions or queries, or would like to ask anything or everything about imaging, then don't be shy. Please feel free to get in touch with me at this email address. So I hope you guys have enjoyed this evening's CPD session. Apologies for not being able